I think it's worth saying a little bit about the background of how I got here. And it is not because I have any background whatsoever. I'm a specialist in hospital-based internal medicine. I have nothing to do with pediatrics, and I've had nothing to do clinically with gender medicine. So that's a good starting point as to my being here. So how did I get here at all? Well, a colleague of mine who I highly respect, but who needs to continue to be nameless, because my colleague very understandably does not want to be pestered by journalists about this matter, had done a systematic review in this area, and I knew my colleague does excellent work and talked with her about it. And somehow I was contacted by somebody from the BMJ writing about it, and because I do not share my colleague's nervousness, I was happy to say, as I understand it, the evidence quality is very low here, and that everything that should be done about it should be, that should be key to any decisions that are made. That was published in a fairly prominent BMJ piece, and now journalists continue to come to me, New York Times, Nature, various other things, where I continue to be quoted. Still not knowing almost anything about gender medicine. And indeed, with that background, if anything I say strikes you as extraordinarily naive or misguided, that probably is because it's extraordinarily naive or misguided. However, I will give it a try about a step back about evidence-based medicine. So evidence-based medicine, people think it's just about the evidence. Well, it's not just about the evidence, and what I'm going to emphasize here, it's about making appropriate clinical assessments, it's about understanding the patient before you, and it's about values and preferences, just as much, or sometimes more, than it's about the evidence. So here is when I talk to lay audiences, I use this example to get them understand the limitations of some of the evidence. So 1,000 people are hospitalized, and you follow them for their mortality. Lots of the people who are hospitalized die. You have a control group in the community, and very few of them die. Conclusion: hospitals are extremely dangerous places, and we would better stay away from them. Now, people, the response here is the one that I usually get. People think this is quite amusing, except as soon as you move out of such extreme examples, people forget this, because what is the principle here? People in hospital are different from people who are not in hospital. But as soon as you move outside of other settings, people forget that in what we call observational studies, hospitalized and not hospitalized, gender dysphoria who undergo certain treatments or those who go other treatments, these people are different, but people forget that, okay? So in terms of gender dysphoria, I was wondering how all the speakers could see they don't look around for their slides, and then I realized it was at the back. However, if I had known that that was going to happen, I would have made my print a lot bigger. Okay. Here we have, so let's put that principle into the gender dysphoria situation. So you have 1,000 people who undergo whatever treatment that you are thinking of, say hormonal therapy, and you see how well they do. And you find most of them do well, a few do not so well, and a few have disastrous outcomes like suicide. And so you conclude that the treatments were responsible for these outcomes. Unfortunately, it may be that the treatments aren't responsible for those outcomes, because you don't know what would have happened had they not been exposed to those treatments. Perhaps without those treatments, everybody would have done well. Perhaps without those treatments, those who have done well would have done badly. Perhaps there would have been no suicides. Perhaps there would have been more suicides. We do not know. And that is the essence of the problem, that we do not have appropriate controls. So you can have some controls, and as you've heard, you can do adjusted analyses. but adjusted analyses, we believe, are always limited. And that's why we need randomized trials. And I heard in a prior conversation, could we do randomized trials? Well, again, very naively, I think with the right commitment, we may. You could take people presenting and say, okay, you'd like to have, for instance, take some hormones, you want to do something, but how about, are you so sure it's a good idea? What about waiting a year? And people might say, yeah, that sounds not unreasonable. You could then randomize people to get it now or get it or wait in a year and see what happens. Perhaps completely out of the question given the political or other circumstances, but in theory, possible. Okay, so turning to what has been one key to evidence-based medicine, which is the hierarchy of evidence. And the hierarchy of evidence recognizes that clinical experience is a source of evidence, basic research is a source of evidence, the observational studies that we're talking about, comparing exposed to unexposed, is a source of evidence, but they all have limitations, and that's why we say there's only low quality or certainty evidence available, and that's why we do randomized trials at the top of the hierarchy. This is a very simple hierarchy that served us well for a considerable period of time, but we have a new and we think it's definitely more sophisticated, and we think much better. It's an approach that we call GRADE, and it was developed to get a more sophisticated approach to rating the certainty of evidence and a more sophisticated approach to going from evidence to recommendations in guidelines. And you've heard about what's happening in different countries when you have a countrywide attempt to look at what's happening in the evidence and then generate appropriate guidelines. So GRADE is I would argue, I'm very conflicted, I would argue now the pinnacle of evidence-based medicine in terms of deciding on quality of certainty of evidence and moving from evidence to recommendations. And part of the reason I can say that with reasonable confidence is that it's been very widely adopted over 110 organizations worldwide, including the World Health Organization, Reading American organizations, NICE in the UK, and so on and so forth, have adopted GRADE because we'd like to believe they realize that we've done a good job in creating a system for looking at quality of evidence and moving from evidence to recommendations. So how does it work? 4 categories of evidence: high, moderate, low, and very low quality evidence. And randomized trials start as high quality evidence, but they may not end up as high quality evidence. So if they are unconcealed, unblinded, and lose patients to follow-up, they have risk of bias problems. If they have small sample sizes and wide confidence intervals, they have precision problems. If the population studies doesn't match the population of interest, they have what we call indirectness problems. And if the results from study to study differ and we don't understand why, they have inconsistency problems and also possibility of publication bias. So randomized trials can start as high, but with these problems it could be moderate, low, or even very low. Observational studies, we've already talked about their problems. That's why they start as low quality evidence. In rare situations, like hip replacements, like epinephrine in an anaphylactic shock, like insulin and diabetic ketoacidosis. Everybody used to do badly. Now lots of people do well. And we have very large effects, and we can have high-quality evidence from observational studies. So this is a much more sophisticated hierarchy of evidence, which we now believe serves us well in terms of applying evidence-based medicine. So, but that GRADE is flexible, okay? So when might observational studies yield high-quality evidence? Well, we've heard that in the Nordic countries and so on, this won't happen until they're over 18 at least, but some individual with transition has a mastectomy and has complications from the mastectomy. We will have high-quality evidence about the complications of mastectomy because you don't have any complications of mastectomy unless you have a mastectomy. So you don't need a control group to know that we have high-quality evidence. So GRADE is flexible and it's not a rigid system. So it's very important when you look at the evidence to develop guidelines, and we have standards for trustworthy guidelines. So GRADE says, okay, the first thing you decide, are you going to recommend in favor or are you recommend against? And it's going to be a strong recommendation or a weak or conditional recommendation. What might determine the direction and strength of the recommendation? It is going to include the magnitude of the benefits and the harms and burdens that go with it. The quality of evidence is going to affect it. And as you will see, values and preferences are crucial. And we have other issues that we've more recently emphasized, including equity, acceptability, and feasibility. So implications, we like this binary category of strong versus weak recommendations. And one reason we like it is we have a way of thinking about it where we say a strong recommendation would be if all or almost all fully informed people would make the same choice. A weak recommendation is when people make different choices, which may be largely due to values and preferences that I will come to. The other reason we like this hierarchy is I have the great privilege of going around the world and talking to various medical audiences. And when I go around the world, there is one question that I can ask any audience around the world of clinicians, and they will always give the same answer. And that question is, do you feel you have enough time to comfortably spend with all your patients to do the job? And the answer universally around the world is no, we do not, which means that we have to have a rationing process for our time with our patients. And GRADE helps with that. Because if there is a strong recommendation, if a guideline panel has got it right, all or almost all fully informed patients would need the same choice. You don't need a detailed shared decision-making process under those circumstances. You can just say, this is what we think we should do, and this is why we think you should do it. On the other hand, when you have a weak or conditional recommendation, it says people's informed choices are going to differ, and you'd better spend the time, ideally with those patients, finding out what's right for the patient. We now are trying to make shared decision-making more efficient with decision aids. Maybe not necessary with a strong recommendation, necessary with a weak or conditional recommendation. You're going to be participants in a study that one of my colleagues has done to show how GRADE and evidence-based medicine thinks about values and preferences. There's a condition called atrial fibrillation, which is an abnormality of the heartbeat. In people with atrial fibrillation, they are at higher risk of stroke. Well, let's take a situation when you have 1,000 people and they have a 12% risk of having a stroke because they have atrial fibrillation. If you give them anticoagulants, you reduce the risk of stroke from 12 strokes in 100 to 4. So you're preventing 8 strokes, and 4 of them are going to be major strokes, and 4 of them are going to be minor strokes. And what my colleague, Dr. Devereux, asked his participants in his study, some of whom were patients and some of whom were clinicians, how many serious gastrointestinal bleeds would you tolerate? Because the anticoagulants that prevent strokes cause the bleeds. How many would you tolerate and still use anticoagulants? Well, Dr. Devereux had to make sure that his patients and sometimes maybe his clinicians understood what it was to have a major stroke and a minor stroke. I'm going to let you read this for a minute so you have an idea of what it is to have a major stroke and a minor stroke. He also needed to have his participants understand what it is to have a major gastrointestinal bleed. Here is what it is to have a major gastrointestinal bleed. Now, 100 patients, they're going to have 12 strokes, half of them major, half of them minor, if you don't give them anticoagulants. If you give them anticoagulants, the strokes go from 12 to 4. You're saving 8 strokes. 4 of them, you're saving them from having major strokes. 4 of them, you're saving from having them minor strokes. How many gastrointestinal bleeds in those 100 patients would you tolerate and still use or recommend to someone to use anticoagulants? Any questions about what I'm asking you? We're okay? Okay. Would anybody accept 5 or fewer bleeds to prevent 8 strokes? In other words, if it's more than 5, no anticoagulant. Anybody? If it's 5 bleeds or less, okay, but more than 5 bleeds, no anticoagulant to prevent the 8 strokes. How many would accept 5 or fewer bleeds? Anybody? A couple of people, three, 4 people. How many would accept up to 10 bleeds but no more? Okay. Yeah, once you've said 5 or less, then you're finished. Okay. So up to 10. Okay. How many would accept up to 15 bleeds? Okay. Anybody over 15 bleeds? Okay. And a number of people over 15 bleeds. Okay, good. All right. Here's what happened when Dr. Devereux asked his clinicians and his patients. The clinicians, a pretty flat distribution. Some of them accepting very few, some more. This audience was kind of like that, except you were more shifted to the upper end. But look at the patients. 2/3 of them would accept 22 bleeds. Why 22, you might ask? Seems like an odd number. Because when Dr. Devereux designed his study, he was thinking like a physician. He thought nobody would choose more than 22. Had you given them the opportunity, they would have. Okay? What are the messages here? The messages here is that the patients are much more stroke averse and the clinicians are much more bleeding averse. That's the first message. And if we follow the clinicians' values and preferences, the patients won't get what they would have chosen. The second thing is, although overwhelmingly the patients are much more stroke averse, not everybody. There's a few patients down at the other end who are as bleeding averse as the physicians tend to be. So if you really want to get it right, you have to do individual shared decision making to find out where a patient stands with respect to their stroke and bleeding aversion. And this is a key principle of evidence-based medicine. Evidence by itself never tells you what to do. It's always evidence in the context of values and preferences. So what are the values and preferences when we're talking about gender dysphoria and the interventions available for gender dysphoria? And here again, I may sound very naive, but it has struck me that it's how the extent to which we value the autonomy of the young person and perhaps their family who are involved in the decision, and how we know there's possible harm down the line, how much we value avoiding that harm at all costs, okay? And that seems to me the value and preference issue that's at the heart of this. So we acknowledge the low quality evidence. We're not sure of the benefits. There's probably some harms, but that's the trade-off that we are facing. Okay, I've been also asked to talk about not only, I focused on interventions, I'm going to talk briefly about evidence-based medicine and diagnosis. So the key to evidence-based medicine and diagnosis, which again our grade system addresses, the key thing is that clinicians often think of diagnostic tests and things we call sensitivity and specificity, but what they should be thinking of is if you use test strategy A versus test strategy B, what's going to be the effect on patient-important outcomes, their deaths, their strokes, their quality of life. So what GRADE says is in GRADE diagnosis, we're going to compare one diagnostic strategy to another. And ideally, we would have a randomized trial. You randomize them to diagnostic strategy A versus diagnostic strategy B. But if we don't have that, if all we have is the properties of how the diagnostic test works, we have to model what might have happened if indeed we had, if we did have the direct comparison that we would like to have. And we also, GRADE applies to prognostic studies. And prognostic studies may be very relevant to this area because it seems clear that some people, maybe quite a few, of the young gender dysphoric people will do well with early therapies. On the other hand, it seems some may not do well. So wouldn't it be nice if we could identify in advance those who will do well and those who will not do well? And that surely, it seems to me, when you talk about future research, that should be one of the areas here. Can we identify the people who are going to do well and not so well? We obviously have heard very vividly that prior psychiatric problems are going to continue. Those people are not going to do well. It's been noted that kind of selection has already gone on. But the more we know in terms of prognosis, the factors that are associated with doing well and not doing well, that would be useful. And again, GRADE has a system of judging the quality of the evidence around prognostic information. So in conclusion, evidence-based practice involves understanding your patient, understanding the relevant evidence, and tailoring the approach to the individual patient's values and preferences. The GRADE approach is a now well worked out system for deciding on the quality of the evidence, high, moderate, low, or very low, and moving from evidence to recommendations. So there is evidence-based medicine in a nutshell. Thanks very much.